So these studies did not show any benefit either on mortality or in disability in these patients. Another study which used magnesium sulfate for neuroprotection in acute stroke also didn't show any differences in disability and 3 months mortality. And the last study was the pill fast in which lisinopril was used, but again, there was no difference in mortality between the two groups. So the guideline recommends that recommends against the routine blood pressure lowering in the pre-hospital setting in patients with acute stroke. Now, moving to the acute care of these patients, we have to deal with two categories of patients: the patients that are eligible for reperfusion treatment and the ones that they are not. So, in patients who are not eligible for reperfusion treatment, we have a lot of studies. We know that elevations in blood pressure over 140 and 160 are detected in the majority of patients, more than 80 and 60%, respectively, in patients with acute stroke. And we also know that both elevated and low blood pressure have been associated with poor outcome after stroke. In this, let's say, old study by Vemus and colleagues, we show that both systolic and diastolic blood pressure have a U-shaped curve with regard to the relation between blood pressure and acute stroke and mortality. A lot of studies that were done in the past, like the VISTA collaboration, the CHIPS, the COSACs, the INOS trial, the SCAST, and the CATIS trials, all these trials, in all these trials, there was no significant benefit either of cardiovascular endpoints or functional outcome by lowering blood pressure in acute ischemic stroke. And on the contrary, the early administration of antihypertensive treatment and the intensity of blood pressure lowering were associated with early deterioration, poor neurological outcome, or death. The most recent meta-analysis was done by the European Stroke Organization panel with, as you see here, 18 trials were included. With regard to mortality, no effect on mortality was found, and also no effect on disability, on functional outcome, was found as well. So the recommendation of the European Stroke Organization suggests that in patients with acute ischemic stroke and blood pressure below 220 over 110, in which they are not eligible actually for thrombolytic treatment, the suggestion is against the routine use of blood pressure lowering agents, at least for the first 24 hours. With regard to patients that have blood pressure above 220 over 120, the careful blood pressure reduction of about 15% in the systolic blood pressure in the first 24 hours is reasonable and likely to be safe. Now let's move to patients with acute stroke, but who are eligible for intravenous thrombolysis. Here we have the first study that was done in the United States, the first study with thrombolysis, in which there was a contraindication for initiating thrombolytic treatment in patients having blood pressure above 180 over 105. These data are not randomized, but on the other hand, both the American Heart Association and the European Stroke Organization guidelines endorse these thresholds. And in addition, there is an appropriate concern that the aggressive blood pressure reduction may reduce viable penubral tissue and result in expansion of the cerebral infarction and contribute to the neurological deterioration in these patients. But on the other hand, the elevated blood pressure levels before or during intravenous thrombolysis may be related to a higher risk of the intracerebral hemorrhage and a lower 3-month good functional outcome. A very large meta-analysis that was done in 2017, which included, you see, more than 300,000 patients with ischemic stroke, and of which 26% of the patients received thrombolysis. It was found that there was a J or U-shaped relationship between blood pressure outcomes. As you can see here, with regard to in-hospital mortality, for systolic blood pressure, diastolic blood pressure, mean arterial pressure, and pulse pressure, there was the J or U-shaped curve. But what was also found in this meta-analysis was that the lower the blood pressure, the systolic blood pressure, the lower the risk for hemorrhagic complications. And on the contrary, of course, the higher the blood pressure, the higher was the risk of hemorrhage in these patients. The next study which examined this hypothesis was the Enchanted trial in Lancet 2019. And in this trial, two targets actually of systolic blood pressure were examined, the intensive one and then what we say guideline recommended. The difference between the two groups of patients was only 7 millimeters of mercury. And in this trial, no significant effect was found in the disability. But what was shown was that there were fewer intracranial hemorrhages in the intensive group. However, as in this trial, in this post-hoc analysis, the patients who received an intensive blood pressure lowering treatment significantly increased the 3-month mortality, despite the fact, as we saw before, that there was a significantly lower clinician-reported intracerebral hemorrhage. So, what is the suggestion? What is the recommendation in patients with acute stroke in whom thrombolysis is indicated? In these patients, we should keep the blood pressure below 180/105, at least for the first 24 hours after thrombolytic treatment. And the suggestion is against to go very low, to lower the systolic blood pressure to a target of 130/140, compared to lower than 180 during the first 72 hours following the onset of the symptoms. The same actually are the guidelines from the most recent ESH, European Society of Hypertension guidelines, in which, as you can see, for ischemic stroke, there is a classification of the patients between the ones who can have a thrombolysis as a treatment and not eligible for treatment. And again, we have the same actually targets for systolic blood pressure. Now let's move to the last part of management of these patients, the secondary prevention. And it's very important to reduce the blood pressure in these patients, since we know that the annual risk of a recurrent stroke is approximately 3 to 4% for every year. This is for every year. And we know that from a lot of studies, the blood pressure lowering reduces the risk of recurrent stroke as well as cardiovascular events, and that antihypertensive treatment has been linked to a reduction in 1 year recurrent stroke risk by 20 to 30%. So you see that this is very important. We have a lot of meta-analysis here. The first meta-analysis was done in 2002, yes, included about 15,000 patients, and the follow-up was up to 5 years, and it was shown that blood pressure lowering reduced the risk of recurrent stroke after a stroke or TIA. You see here the first 7 studies that were included in this first meta-analysis, and we see the SCOPE study and the PROGRESS, two very important studies in the past. You see here from this meta-analysis that the risk of all stroke was reduced by 24%, and also there was a significant reduction in the risk of non-fatal stroke, myocardial infarction, and vascular events, cardiovascular events. 2 other very important studies that were done later on was the PROGRESS and PRESCENT, in which again there was a 15% reduction in cardiovascular events, in which stroke was included as well. And the meta-analysis in 2009, also another meta-analysis in the National Archive of Medicine, with the same studies. With also these meta-analysis also included the PROGRESS and the TRANSCEND trial. There was about 30% reduction in recurrent stroke, and also this meta-analysis in hypertension research. You see here that PROGRESS and TRANSCEND were included, a 22% reduction. A very good meta-analysis that was done by a Greek panel with Professor Tsiboulis, in which You see 40,000 patients were included. You see all these trials, 14 studies were included here. And again, we see that there was a 27% reduction in recurrent stroke, in about 30% of disabling or fatal stroke. And of course, most importantly, there was a reduction, significant reduction in the cardiovascular death. So in patients with ischemic stroke or TIA, should we lower the blood pressure? Of course, in this meta-analysis of 9 trials that was done, this is the most recent meta-analysis by the European Stroke Organization panel. In these meta-analysis, 9 trials were included, and again, there was found a reduction by almost 20%. And you see here, this is important to see that we expect about 17 fewer strokes per 1,000 patients treated. You see here the studies that were included in this most recent meta-analysis from the European Stroke Organization. There was also a significant reduction in this meta-analysis in major adverse cardiovascular events and in cardiovascular death. There was no significant reduction in myocardial infarction and all-cause mortality, and there were insufficient data to allow analysis for the effect of treatment that you see on dementia and functional outcome. So the suggestion, the recommendation from the European Stroke Organization for the quality of evidence of high and strong strength of recommendation, as you can see, is that we should reduce the blood pressure in these patients. Now, what are the blood pressure targets we have to aim in these patients? Should it be lower than 130/80 or lower than 140/90 millimeters of mercury? Again, from this meta-analysis, with the 14 studies I showed before, in this meta-analysis, it was shown that systolic blood pressure of below 130 was better than systolic blood pressure above 140, and this was also true for diastolic blood pressure, in which diastolic blood pressure lower than 85 was much better, as you see here, for all stroke compared to diastolic blood pressure above 90. 3 major trials were done with regard to the intensive versus non-intensive blood pressure target in these patients. That was the SPS3, the past blood pressure in podcast. From this meta-analysis, was done by Cochrane, it was shown that there was about 20% reduction in stroke risk. And later on, after the publication of these trials, there was another trial, the RESPECT trial, that was published in 2019 in JAMA. And when all these trials were put together, it was shown again that there was about 22% lower reduction, incidence of recurrent stroke in these trials with intensive treatment. So the recommendation here is that we should aim for a blood pressure target of below 130/80. The quality of evidence is moderate, but there is a weak strength of recommendation. Is it important which exactly antihypertensive class drug medications we should use? There are some meta-analysis on this matter, and it was found from the first meta-analysis in 2003, as I said before, that diuretics and the combination of a diuretic with a RAS inhibitor was better than the other antihypertensive medications. Also, in another analysis, it was found the same, that the diuretics and the combination of diuretics with the RAS inhibitor, and also in this meta-analysis by Tsibulis and Paul, it was also found that you see antiadrenergic drugs were not significant, the beta blockers, the calcium channel blockers, and the RAS blockers, but the combination with thiazides and thiazides themselves were effective in reducing the risk of recurrent stroke by about 30%. Now, to conclude with the guidelines, the American guidelines with regard to the secondary prevention of stroke and the blood pressure. In patients with hypertension, treatment should be initiated either, you see here, with thiazide diuretic, angiotensin enzyme inhibitor, any drug actually. And the Americans note that the magnitude of blood pressure lowering appears to be more important for risk reduction than the class of antihypertensive agent use. The goal is, excuse me, below 130/80. The same also stands for the European Stroke Organization. We should lower the blood pressure, and the target should be 130/80. And the most recent guidelines of the European Society of Hypertension also agree that we should start blood pressure lower treatment after stroke to reduce the risk of recurrent stroke. The first and main goal should be to reduce blood pressure below 140/80, and in patients that they can tolerate, the blood pressure target should be below 130/80. Systolic blood pressure values lower than 120 should be avoided. And these recommendations actually are applicable to individuals younger than 70 years old. And we all know that every time we should individualize our treatment according to the functional and status of the patient. And the last thing, that there is an uncertainty if there is any benefit in patients with a previous stroke and blood pressure in the high normal range or lower. Thank you very much for your attention.